Thanks, Wande, and thanks everyone for another really stimulating session. I think we're going to try and change tack a little bit now. We've had some presentations, we've had some Q&A, but now we'd like to up the interaction amongst all the participants and everyone here at the workshop. So we're going to go into a sort of case study format now to close us off for the day. You all listen patiently today. As I said, these are two half-day sessions that we're holding for this workshop. So we've got 3 hours today in total, and then 3 hours tomorrow. I'd like to introduce our moderator for the case study. He came up with a case study, great colleague of ours here at Chatham House, Dr. Osama Ahmed Hassan. Osama is an associate professor of One Health at Umeå University in Sweden. He has his background is originally from Sudan. Osama has substantial experience of over 21 years, and his work is based on 3 pillars of research. 3 pillars: teaching, research, and operational service. His research focuses on threats at the human-animal environmental interface, and obviously using the One Health approach to confront these issues. He has been involved in many preparedness and response projects for emerging infections across Africa, the Middle East, and the European Union. So we're really pleased to have Osama here lead us through this this case study, which is around vector-borne diseases. So over to you, Osama, to bring us to a close for today.
Thank you so much, Dr. Osman, for this introduction. Would you step down the slide from your side so I can share mine? That is great. Good. So simply, I'm going to have a simulation case study for mosquito-borne disease, taking Rift Valley fever as an area. Sorry, taking East Africa as an area for this mosquito-borne disease. The scenario start just like that. Early warning system of the Food Agricultural Organization of the United Nations notifies countries in East Africa that heavy rain is expected to be in the region during the rainy season in year X. And the alert stated that the expected condition will alter vector-borne diseases both in animals and humans. The advice made by the FAO that the East African countries should strengthen their early warning system and surveillance to be able to predict and detect, respectively, any vector-borne zoonotic disease. Okay, with this background at this stage, let us just say a few words about what is the difference between early warning system and surveillance. So is there any difference between early warning system and surveillance? Okay. So let me take it further from here, and then I will I can see if hopefully you'll be interactive and share in the chat, but also raise your hand. Usually, early warning system predict conditions actually that lead to predict adverse conditions that lead to outbreak. And while the predict early warning system offer us great opportunity of lead time for preparedness on the ground. But the surveillance system itself is a systematic collection of the data and aggregation of the data related to the disease of interest. And if the threshold of this, the level of the cases of diseases exceeds the threshold, that means the surveillance will be able to detect the outbreak. So the data to feed early warning system, it's going to be different from the data that feed surveillance system. So what type of data might be collected and analyzed to enhance the early warning system with the difference that I mentioned? and what type of data that can be actually included within the surveillance system. So let's start with the early warning system. What kind of data that we can actually feed such early warning system with this background? Any suggestion? At least in the chat. Excellent. One mentioned rainfall data. Someone said, please raise your hand. Okay, that's good. Yes. So that's really great. This is exactly because yes, environmental data in general, that is great. This is exactly what we said, because this is the prediction and model. So environmental data, climatic data, those would allow us to know what is going on the ground, like the level of the rain, absolutely. Another environmental data, like what is called NDVI, vegetation index, absolutely vectors, that absolutely will be really useful to allow us to understand actually the situations and the trigger factors of the suspected vector-borne disease. Indeed. So yeah, all of this environmental data, temperature data, absolutely. Temperature data also has a lot to do with vectors. Abortion cases, if we say abortion cases, I think now we are started talking about cases and not the adverse condition. So maybe this abortion or aborted animals cases, this is going to be a part of the surveillance. While clinical data is going to be a part of the surveillance. Demographic data, clinical data, those will be a part of the surveillance. Okay, so let's go ahead. Thanks for this contributions. So in rural area of country X in East Africa, and after 1 month of the rainy season and higher temperature than the average, many persons have developed febrile illness and sent to the near rural hospital in the region. And some of the patients have been seriously sick. And later, after a few days, some of them have developed signs such as petechial hemorrhage, meningitis, ocular problem, and even renal failure. And the total number of the patients was 45. And interestingly, it includes both men and women. And also it includes young people like students at the school. As a background, the total population of the village is about 2,000. Okay, so now we know that we have people hospitalized, and what demography belonging to. The question, in this situation, we need to carry out research actually, and we know that sometimes we at ministries, we do not have the right capacity at the right time to do this research. And this means we need to incorporate academic research institutes and universities. So how do we do that? In order to allow them to help us to conduct the research, to be a part of our team, and to take part of this research, or maybe even to take lead. So do we need to do this collaboration just at the time of the outbreak, or should we set such a kind of strategic relationship with the research institutes exist in the country, including universities? Okay, so absolutely, there must be a system in place, but this is not the case in reality. In majority of our African countries, this is not the case. We lack this sustainable collaboration setting with research institutes. We really need to think of this. This is quite important because those people are well trained actually for research. With the cooperation with us, with the technical inputs from ministries, involved in such a kind outbreak, absolutely this combination is going to be fantastic, and it will lead to evidence-based absolutely later. So how we deal with the research ethic clearance in such a short call? I think there was another workshop earlier about that also, and this is challenging. But I think also we need to find a way to set a system with the research committee or research body in the country, allowing very fast track for such kind of research. This cannot be done at the time of the outbreak itself, but absolutely we can establish system like that without any exemption. I mean, in the ethical principles themselves, but rather we do it in a very fast way. At this stage, what type of samples can be collected to identify the possible type of this disease? Now we are just talking about patients administered to the hospital and hospitalized there, and they developed some symptoms. Yeah, for example, blood samples, that would be good. Any other samples, biological samples, that would be good at this stage because we do not know about the disease so far. So it depends on the experience of the clinicians and the data that collected, absolutely. And what other type of data that can be collected at this stage? In addition to the biological samples, yeah, and all of them blood and urine samples. Thanks for you. You are active in the chat. Yes, demographic data. Thank you so much. Indeed, demographic data at this stage, we need to collect demographic data from the patient. And how we are going to collect this? What kind of data collection tool that we will use to collect this demographic data, for example? Are we going to have a questionnaire? Are we going to have an interview based on the questionnaire? What would be the best setting? Questionnaire, okay. Interview, yeah, that sounds good. It depends on the setting, but you know, when you decide about this collection tool, you really need to know very well what type of questions will be addressed through this data collection tools, and how we are going to analyze this data. You need to be sure that each question representing an important variable in your analysis later. And this is exactly what Vincent said earlier, that we need to consider these issues of data analysis, data planning earlier with more specialized people like a statistician, rather than collecting the data and then just later doesn't know what to deal with it, and if we collect the right data or not, which could also create an ethical question. Why did you collect that data if you do not know how to do with this? Okay, what type of study design can be conducted to identify potential risk factor? Earlier, we talked about the potential disease. We tried to know about it, but now we need to know about the risk factor within the setting of this patient in the hospital. Okay, any suggestion? I like that the people are really active. They are just like, okay, can I use this? Yeah, just checking that. So you'll be surprised if I'm saying that there is a noise outside. This is the tractor trying to take out the snow. This might be a big surprise for you. You are enjoying the sun there in Africa, but I'm in the north of Sweden. Oh, I like that. Someone said quantitative studies, and particularly case control study. One said cross-sectional study. Well, good. Let us justify rationale why we need a cross-sectional study and why we need a case control study. Okay. So in order to identify the magnitude of the problem, the incidence or the prevalence, then we go for the cross-sectional study. But here we are talking about the risk factor. So for risk factor, in some cases, if you design the cross-sectional study in a way that you can calculate what is called prevalence odds ratio, okay, you can also calculate the risk factor, but usually this is not the most. Yeah, someone need to mute. I think you need to mute your mic, someone, or maybe someone from the. You need to mute your mic. Okay. Yes. So for risk factor right now, maybe we can come to the attack rate later. But maybe for risk factor, a case control study would be really fitting here, because we have already the cases in the place. We have the patient who developed this disease so far, and we took samples to identify the possible cause, but we need to know the possible risk factor that led to this cause. So, okay, good. So the cases are there, but what about the control? From where we will select the control? Okay, someone want to talk? Okay. Norbert, I think you wanted to talk. Go ahead, please, if you want to talk. Okay, control from the population. Can't we take the control from the hospital itself, from people that in another department hospitalized, but they don't have same clinical size? If we take the control from the hospital, or we take them from the population, what is the difference? What is the advantage? Yeah. If we take them from the hospital, it might be challenging. The control might not be representative. We know that not all the people come to the hospitals, just maybe. So we might be in a selection bias. If we take them absolutely from the population, this is going to be really very mostly very representative, and it could pick up the real picture actually, and particularly from the area where the outbreak took place. Yes, from the population that shares the same chance with the case. Yeah, great. This is really good. So let us go in the scenario. Later, a team from the Ministry of Health was formed to investigate the possible etiology of this suspected disease. After interviewing the patient and their families, the team recognized that many of the patients were working with animals either as breeders for men or taking care of animals at house for women. Among the patients, there were also persons who had no contact with animals from the same area. Okay. With this information, additional information, as an investigation team, what a preliminary epidemiologic hypothesis could you set up with regard to the suspected disease? I said the team from the Ministry of Health was formed to investigate the possible etiology of this suspected disease. After interviewing the patients and their families, the team recognized that many of the patients were working with animals either as breeders for men or taking care of animals at house for women, but also there were also persons who had no contact with animals from the same area. Excellent, excellent. Someone said, so Frankfurt said, yes, zoonotic. Yes, so disease is transmitted from animal to humans or between humans and animals. Zoonotic, likely the etiology is with the contact of animals. It is, yeah, zoonotic disease. Yes, so the hypothesis would be, yeah, very good interaction, indeed. So yes, so this is the preliminary hypothesis could be that, yes, this is a zoonotic disease. Okay, the investigation team was deployed to the affected area and started the investigation. They listened to rumors from the villagers that they have noticed an abortion in ewes and deaths in lambs and calves in the area. The villagers were reluctant to talk to the team as they were concerned about their animals to be quarantined in the area and even to be culled, to be get rid of. So the first thing that the team did was to expand the team disciplines and ask it to include veterinarians to deal with the suspicion of the disease at the animal side. Okay, So then the integrated team continued its investigation, and they observed that colonies of mosquitoes spread in the affected area. So the team thought again that they need entomologists to be added to the team to investigate the possible link between the mosquitoes in the area and the suspected disease. Further investigation that was carried out by the team in the affected area showed that there were many of the villagers have developed fever and flu-like disease in the last weeks, but they recovered in few days. Okay. So we have three parts of this information here. That the information, the team, when they went to the affected area, they listened to rumors from the villagers that there were noticed abortion in aves and deaths in lambs and cows. And also they recognized that the villagers were not interested to talk about this to the team because they were concerned that their animals might be quarantined in the area, so they cannot move to seek grass or even source of water. And to some extent also they were worried that if they would be asked that to get rid of their animals. So here the team decided to expand their disciplines and included veterinarians. While they are furthering investigation the situation in the affected areas, they notice that also there is colonies of mosquitoes. So here also they recognize that, well, we lack entomologists, so we need to have them. This is their area of expertise. While the team was established very well from all of these disciplines, veterinarians, entomologists, and people from health sectors, in fact, while they are investigating, they found more information that within the time of their investigation, or just a few days earlier, that there were many villagers developed fever and flu-like disease in the last weeks, but they recovered rapidly. So with the suspicion that the disease has occurred at the human, animal, and environment interface, what type of data needs to be collected from the One Health perspective to develop a case definition for suspected case disease in animal and human? You know that in order to gather important data for the surveillance system, you need to have a case decision. Now they collected information about focus on animal and humans both, and also maybe the relation to the environment in terms of mosquitoes. So what type of data that can help them to define the case definition properly? Okay, data from suspected animals, vector and blood samples, great. Multisectoral data, that, yeah, good. Symptoms in animals and humans, absolutely. Vector data, great. Absolutely. So we could mention the symptoms in animals for the definition of animals. We could mention also if the humans are being in contact with animals, if they have been exposed also to vectors or mosquitoes, and so on. Yes, and clinical data. Yeah, that's a general answer, which is acceptable. What type of data needs to be collected from One Health perspective to identify the possible cause of the suspected disease? We remember that we collected blood samples or any other biological samples at the hospital, but now we are in the field, in the area of the outbreak itself. So what type of data that we can collect here actually to help us explore the possible cause of the disease? Well, mosquito collection, blood collection, absolutely. Human and animals, yes, indeed, that's important. So now we are talking about animal samples, human samples, and also environmental samples, mainly mosquitoes. Yeah, that sounds great. What is or are the tools to be used to collect the above mentioned data? Those data for identifying the possible cause of the disease. So when you collect those samples, are you going to just write the names and this is just like a blood and like that and you stop here, or you would have maybe a form associated with that? Yes, yes, that'd be good. Yeah, electronic tools. If that's not possible, if you are working in remote field, that was not possible. Just paper tools can be also enough. So you can connect the demographic data and other clinical data to that samples of the observation. This is applicable for both for animals and for human. And also maybe more information, if you collect mosquitoes, you can write more information about the areas the mosquitoes collected, and yeah, describe some of the ecology. That would be good. Well, was it enough only to include team members from the health, veterinary, and environmental sectors to collect reliable data to have a holistic understanding of how the suspected disease has emerged? Community villager leaders, okay, good. Line listing, okay. Community members, okay. What else of disciplines? Yes, absolutely. Community in the heart of that. Community health worker. We need public health specialists. Yeah, those would be already there. Design software. Well, social science. I'm waiting for that, Farah. Absolutely. I would expect ecologists, and those are already there, and entomologists. But social sciences, we didn't mention that in this scenario so far. So social scientists are quite important. And why do we need social scientists? So why do we need them? What is the suggestion? Do you have suggestion to include additional disciplines? You said social scientists. If yes, suggest what type of data that social scientists can collect and how that would contribute to better understand the suspected disease and guide possible intervention. Yes, let us elaborate about social scientists. Yes, human behavior, absolutely, qualitative data, indeed, indeed, indeed. So usually to help understand behavior of the, oh, excellent, indeed. So usually we when we carry out quantitative studies, the quantitative studies are always about magnifying the level of the problem. But if you want to answer the question of why and how the phenomena or the disease occur, you need to go for qualitative studies. And here also the human behavior seems to be quite crucial in the emergence of the disease, because there is an issue of contact between human and animal, and also there is an issue with regard to mosquitoes and mosquito bites. So absolutely, the social scientists here are going to help a lot. And what type of action research can be done at this stage by these social scientists to help control the disease? Yeah, anthropologists, you might have access to knowledge about, yeah, not all of them. Yes, yes, those are quite good answers. Human practices, enhance outbreak, advocacy, public enlightenment. Yes, let me just share the story of Ebola earlier. If you remember when the Ebola outbreak occurred in West Africa at the beginning, the health authorities tried hard with the community to avoid mispractices that increase the chance of Ebola and the spread of the disease, but the response was quite weak, and the suggestion came at that time that we need to include actually social scientists who understand very well how to deal with the local communities, and they know very well how to respect the values and so on. When they involved with the social scientists, immediately the response from the local communities was quite high, and the epidemic curve started to decrease significantly. So absolutely, social scientists are quite good. They can conduct action research here, because the human behaviors can change significantly during the outbreak. So they can manage that, and they can learn from that. The team now managed to collect samples from animals, mosquitoes, and humans, and deliver them to the central animal and human laboratory of the country, respectively. So the cases of the samples of the human went for the human laboratory, for animals went for the animal laboratory. But we'd expect the information sharing here. The human samples from the village were added to the samples that were collected from the hospitalized patient from the village at the rural hospital. So you remember that we have had collected already samples from the villagers hospitalized. So we took these samples from the field and we add them to those one at the central laboratory. The investigation team developed a preliminary hypothesis suggested that the disease seems to be zoonotic disease. Oh, this is just like what you said, transmitted from livestock to humans, and mosquitoes could be involved in the circulation of the disease. So while the samples were sent to the animal and human center labs, new cases were detected in the affected area. That means the outbreak is ongoing. So after 1 week, the laboratories confirmed that this was Rift Valley fever infection in both animal and human. Unfortunately, although we collected mosquito samples, but there was no capacity to carry out entomological competence study to isolate the virus from the mosquitoes, to see what is competent mosquitoes, and to identify the type of mosquitoes or vectors involved in the circulation of the disease. So, and this is a capacity that lacking in Africa. We really need to build this, even if we could do it like in a term of collaboration. We need to have competence, capacity to study actually the competence vectors involved in mosquito-borne or vector-borne diseases. And within outbreak like Rift Valley fever, the first week usually there is a very active type of mosquitoes. In most cases, they are Aedes species. And after the first week, then Culex species taking actually the role after that, and there would be many other mechanical vectors also involved. But in order to have a better understanding of the situation, you really need to have entomological studies. And of course, a part of the control, you need to have intervention against this. But this is also very expensive anyway. And I don't know how this would be done in a very limited resources setting. So disrupting the outbreak, particularly between animal and human, and decrease the amplification of the virus in animals through vaccination, that is going to be the best for the setting of Africa. But if we could build this capacity of vector understanding and vector control, that would be great. So Rift Valley fever is an arthropod-borne viral disease that affects both livestock, sheep, goat, cattle, and camel, and humans. Risk factors are direct contact with infected or reported animals for their fluids, as well as infected mosquito bites. So this is, I'm gonna just shed light back on what I said in the scenario at the beginning. I said that in the hospital, there were patients actually hospitalized, and those patients did not have anything to do with animal contact. So possibly those patients contracted the disease from the infected bites mosquitoes. This could also would be a very good explanation for us, because we should not left any lack of understanding for any available data. So the virus has caused devastating outbreaks in and outside of Africa. This is very well known in Africa. It's a big problem. And by the way, also Rift Valley fever is among the top priority list of WHO of those diseases has the possibility to emerge and cause more epidemic and possibly pandemic crisis. So they are among the top agenda by the tripartite plus. So since Rift Valley fever occurs at animal, human, and environment interface, and it is from the list 1 disease, it is notifiable for relevant international organizations such as World Animal Organization, OIE, and also World Health Organization. So this is very important. If you have a Rift Valley fever cases, you need to notify that to this relevant international authorities. But before the country X could notify Rift Valley fever for OIE and WHO, what further analysis need to be carried out by country X? Okay, let me have a look at the chart. Ecological analysis, okay. Serological tests and mosquito identification using sero, perhaps some molecular studies such as PCR, yes. Okay. Okay, good. Yeah, you know, this is the sample analyze the geographical, exactly the geographical extent of the disease. Thank you so much, Ayu Dewi, because this is a mosquito-borne disease, and we are not sure if the disease is spread to other regions and other areas or not. So we need to have representative samples from the whole of the country, or at least regions at risk, in order to know exactly the geographical area and the geographical expansion of the disease. And then at that time, we would absolutely provide data, specific data of patients and demographic of patients, and absolutely for OIE, but also data about animals and also demographic of animals. This is important, actually. But remember, before we go and notify this kind of international disease, there is what is called reference lab for WHO and reference lab also for OIE. And both of them, they have reference lab in Africa. So we cannot go and announce without sending samples for human reference lab of WHO and animal reference lab of OIE, and they have to confirm that this is, yes, this is Rift Valley fever, confirming the results that we have had on the ground in country X. After they get this confirmation from this reference lab of WHO and OIE, then we could notify WHO and OIE saying, yes, we have had an outbreak of Rift Valley fever. This is applicable for all the other notifiable diseases. Okay, at this stage, yes, great. Yes, confirm it from the reference lab, absolutely. So the outbreak has continued, and the team started evidence-based intervention according to the knowledge that they gained from the epidemiological studies and lab results. So at this stage, what type of data can be collected to identify if the interventional measures were successful in controlling the outbreak? So you knew that the risk, this is a zoonotic disease, it is spread between animal and human, and also mosquitoes playing part. And you started intervening and increasing the awareness and talking to the people, and even try to get rid of aborted animals and just bury them in a very safe way, and try to talk about hygienic measures and the relation between animal and human, and talk to the people to protect themselves from mosquito bites during this outbreak and this rainy season, and so on. So this, how do you know these interventions are functioning well? What kind of data can be collected? Okay, let me have a look at. I think we are managing the time very well so far. Yes, incidence of cases. Yes, if you look at the epidemic curve, indeed, yes. If you look at the epidemic curve, both in animal and human, look, we are talking about one health. It's not only about human. So if you look at incidence in human and animal also, that is going to give you actually, yes, an idea, which is absolutely a part of the surveillance data. Indeed. So the surveillance would show us if the number of new cases increased or decreased. Yes, and yeah, if you have also, if you have entomologic control in the place, like you control the vectors and you spray them and so on, of course you can look at the areas of the breeding of the vectors and see if the density of the vectors are still like before this intervention or not. Yes, thank you so much. Yeah, that could be, yeah, morbidity data. Yes, absolutely. Incidence data. All of them are quite good. And what is the tools can be used? Maybe that we mentioned already earlier. The same like what happened. And what type of study design can be suitable? Could be suitable to investigate the success of the intervention, the issues that we just said. So what type of studies? When you talk about incidence and prevalence, yes, I think the simplest one is the cross-sectional. Indeed. Let me just ask one question. If you have any hypothesis that this patient with Rift Valley fever might develop any complexity or comorbidity in the future, and we want to know about that, could you develop any type of study design? What kind of study design this could be? If we have assumption and that we want to follow and see if this would happen in the future. Yes, cohort study, longitudinal. Indeed, cohort study. And absolutely. And from the cohort study, like if it is a prospective cohort study, so we have the exposure, those people exposed to Rift Valley fever, and we wanted to see if they will develop, for example, meningitis in the future or any other complexity. So we will follow them for the time, and we pick up the cases that would occur. But if we have this cohort study, and we wanted to make a case control study from the cohort group, could we do that? Can we design a case control from the cohort? Yes, good. How? How? What is that called? Yes, okay. Help me how that could be. Nested. Yes, we could have a nested case control study. So we just follow and see whenever there is a cases developed during this observation of the cohort, we take it and we look for a relevant control. So we take the cases again. If there is anyone appear later, we take it, add it to the previous one, and then we look for control and so on until we get enough cases. And of course, we find enough control for them. So nested case control would be also excellent in this case. That is really good. After 3 months, there were no identified new cases of Rift Valley fever in animal or human in the area of the outbreak. Accordingly, the end of the outbreak was declared in country X by post ministries of agriculture and health. In this case, what more data needs to be collected, assessed, and shared with OIE and WHO in order for them to declare that there is no longer outbreak of Rift Valley fever in country X? Okay. Yeah, risk set mapping, surveillance, human, prevalence data. Yeah, so we need to collect data from the whole of the country. Yes, and the surveillance should actually lead that. And absolutely samples, new samples, where we get sure that there is no new. But if there is a vaccination in place, how we are going to differentiate between the antibodies developed from the vaccine and antibodies developed from old infection of Rift Valley fever? Multisectoral samples, absolutely. So samples from humans, samples from animals, samples from vectors, mosquitoes or vectors. So how we can differentiate between this? Oh, IgM and IgG. No, IgG is for old, and both. If you have old infection, you will have IgG. If you have vaccinated also earlier, this is going to be also IgG. So it's not going to be IgM. And that means this is also quite challenging. I think there is a technology, but this is not available mostly in our settings there. So we need to have the history of the animals in that settings, if they were vaccinated or not. And we know just this is also related to the operational part. We do not vaccinate within the affected area of Rift Valley fever, but particularly because we use syringes, and the syringe can really spread the virus between animals, particularly those with febrileness, and we don't know about them. So we would accelerate actually the spread of the virus. That is why we only vaccinate in areas at risk, not the areas already have been affected by the disease. Zero report of the disease, that is important in order to let WHO and OIE announcing that you are free of the Rift Valley fever outbreak. But could the country X, for example, easily announce that they are free of Rift Valley fever for about zero Rift Valley fever? Can that be easily happen? And how long it might take? Okay, so lesson learned, 3 months. No. If you want to say that you have no any other, Rift Valley fever in the country, not only the end of the outbreak. Oh, this is very difficult. Yes, someone said 5 to 15 years. Absolutely, almost 10 years. Very difficult because Rift Valley fever it might have as a reservoir. We don't know. And also the mosquitoes are involved. You cannot actually eradicate mosquitoes there. And that means the virus will be there for a while, actually. It means a lot of efforts. Mostly each country affected by Rift Valley fever almost it's going to be endemic country with sporadic cases from time to time, with inter-epizootic outbreaks in animals, and also sporadic outbreaks in both animals and human. So that is why that's why Rift Valley fever is really challenging to be actually controlled or eradicated even. It's difficult to manage vectors. I absolutely agree with you. And what type of data? At the end of the outbreak, the investigation team was asked by the relevant ministries to write an integrated report using the multi-sectoral One Health approach. What type of data or information that would be included in the report? Yeah, trend analysis. Okay. Someone mentioned earlier attack rate. I think we have to mention it here. Case fatality, we have to mention case fatality. Yeah, prevalence, morbidity and mortality, absolutely. Yeah, epidemiological data, case management, indeed. Yeah, background of the environment, absence of the reported case, date of first index. Yeah, diagnostic tools used there. Yeah, and so on. That sounds good. Yeah, absolutely. This is some of the vaccine coverage data, absolutely, and it has to be from One Health perspective. We don't need to have a separate report for animal sector and for human sector and for the environmental. It's better if we have it integrated and send it to all of them. Yes, and also the intervention applied and how did they how they work it, and the communication strategy, how was it and how did it work? Absolutely. And we need to share that with the right people. Absolutely. Yeah, the demographic data. And yes, this is the distribution of the disease outbreak over time. This is called the epidemic curve. It could be by weeks, could be by months. No worries about that. Yeah, that is good. Thanks, partners involved. Yeah, that's great. Okay, I think we are really doing good also in terms of time management. Let me have a look at the question and answer. I think there were some questions here. In such a study which are linked on one human animal environment data, it is common to struggle with the design and the sample collection on the field, particularly in terms of sample size calculation. What is the best way to capture common risk factors? No, I'm not sure if this is for me or. Yes. So most recent. Oh, there were some questions there, but I'm not sure. Are those questions on the question and answer for me?
No.
Yeah, okay, that's fine. Yes, let me go back to very interesting question. Oh, thank you. Thank you so much. Yeah, that's great. So this is almost very close to a real scenario. In fact, I've been working with Rift Valley fever for a long time, actually, in different countries. And I was also deployed as a consultant by the tripartite to West Africa during the last outbreak of Mali, Niger, and Senegal, and so on. And also, I worked with the outbreak in Sudan, Saudi Arabia. I've been also collaborated with colleagues in Kenya. Yeah. Well, that's great. Anything that you would like to add? I think we managed to do the case study in a very reasonable time. It was a very interactive session. If someone would like to speak, you can also take the mic and raise your hand and speak. We have 8 minutes left. That's fine. Yes, thank you. You're welcome. Yes, they will. Yeah, they will share all of this material of the workshop in the link that attached. So don't be worried. This will be in the Africa CDC website. Okay, up to you, Dr. Osman. I think I'm done in the right time. So still you have 7 minutes to wrap up. Okay.
Yeah. So a lot of the people are thanking you for that session, Osama. And as usual, they're confusing our names because I'm Usman and you're Osama, and there a lot of people are thanking Dr. Usman, but I didn't do anything. So so it's Osama that you need to be thanking, everyone. So thanks for that, Osama, and it's an interesting format that we've used to try and get everybody involved, because of course we didn't want to go into breakouts. We wanted to be able to do this session in plenary. So thanks for taking us through that and giving us a practical perspective from real life experience. Tomorrow we're going to have a similar sort of format. We've got sessions in the afternoon on One Health early warning systems and early warning and response system tools. We've got a session on syndromic surveillance as a tool to strengthen conventional surveillance in Africa. And then we've got another interactive case study session with two moderators who are joining us for the final session tomorrow in the afternoon. So we hope to see you all back here tomorrow afternoon. We start again at 1 p.m. UK time sharp. I guess that's it. Are there any other things from the organizing team? Mercedes, Nicole, am I missing anything?
All good. Thank you, Osman. Remember to use the same link for tomorrow.
Yeah, exactly. Everyone, please use the same link for tomorrow, and like we said, you know, you'll get your certificates of attendance and all of that once we get the evaluation forms and everything back. So it just leaves me to thank all our participants, and in particular all our panelists and our chairs for their wonderful input and insight and sharing their expertise and experience. And I think there are we do have the possibility for you to get some of their contact details if you want to try and set up communities of practice and stuff, and you know, reach out to them as researchers and leaders in this field. Try set up collaborations, try to set up collaborative networks. I think we encourage people to do that, and certainly all our presenters are very accessible and eager to and willing to share their experience and expertise with participants. So again, I want to thank them, especially the panelists and the presenters for sharing their time. They're not paid to do this, so well, at least not paid by us to do this. So we're very grateful for them sharing their experience and expertise. So thank you, everyone, and see you tomorrow in the afternoon. Have a good evening, have a good day, wherever you are, whatever time zone you're in. Take care, bye.